Welcome to this clinical walkthrough on the SimMan emergency scenario case for UKMLA, brought to you by Mediate, your 24/7 practice partner.
So the SimMan station, I know a lot of doctors see this as like the final boss of the PLAB 2 exam. It can feel super intimidating, right? But trust me, we're here to show you that with the right game plan, it's actually one of the most predictable stations you can get.
Because here's the secret. The key to passing isn't about pulling some obscure diagnosis out of a hat. Nope, it's all about showing you're a safe doctor. And you do that by following a simple, repeatable protocol and saying everything you're thinking and doing out loud. Patient safety is the name of the game.
To get you there, we're going to break it all down into 6 parts. We'll start with the challenge itself, then we'll cover your entry into the room, mastering the ABCDE protocol, reading the news chart, nailing the S-bar handover, and finally we'll talk about the core habits for success. By the end, you'll have a solid blueprint you can use every single time.
Okay, let's dive in. First things first, we need to get a handle on the environment you're walking into, and more importantly, what the examiner is really looking for.
And this right here reframes the entire goal. Your job isn't to figure out the final diagnosis. Your number one job is to be safe, to be systematic, and to verbalize every single thought and every single action. You only fail if you let the patient die by missing something critical. Do the basics safely, and you're well on your way to passing.
Okay, so let's build on that. How you enter the room and what you do in that first minute. It sets the entire tone for the station. It's your first chance to show the examiner that you are in control.
These first 4 steps are absolutely non-negotiable. You knock, you enter, you greet the examiner. Then you state out loud, "I've taken all universal precautions and ensured scene safety." And you immediately turn your attention to the patient and introduce yourself. This shows professionalism and awareness right from the jump.
And right after that, you're scanning the room. You're taking a quick look at the monitor and you're reassuring the patient. Even though it's a mannequin, you speak to it with empathy. Say something like, "You're in safe hands." Then you can try to get a quick history and always gain consent. This establishes control and builds that immediate rapport.
Now this brings us to the absolute core of the station. This is where you're going to use a systematic approach to assess the patient, do something about it, and then, and this is so important, reassess to see if what you did actually worked.
Now, your first move is going to adapt depending on the patient's state. If they're talking to you but clearly struggling, you acknowledge it, you call for help, and you get them sitting up. But if they're just mumbling or seem confused, you've got to check their response, check their wristband, call for help, and assume their airway is at risk. But here's the key. Both paths lead you straight back to your ABCDE protocol.
So A is for airway. Your goal is to make sure it's open, right now. You need to say what you're doing. Is the patient talking? Great, airway's patent. If not, I'm listening for any gurgling or stridor. I'm looking in the mouth for any obstructions. Start with simple things like a head tilt chin lift before you move on to suction, airway adjuncts, and high flow oxygen.
Next up, B for breathing. You've got to do and verbalize a full respiratory exam. Look, feel, tap, and listen. Then, you have to connect what you find to what you do. Hear a wheeze? You give a nebulizer. Hear crackles that sound like edema? You're thinking about furosemide. And then you state your investigations. I'd like a portable chest x-ray and an ABG.
Moving on to C for circulation. If that patient is showing any signs of shock, low blood pressure, slow cap refill, your brain needs to be screaming, "Access." That means getting in 2 wide-bore cannulas, drawing bloods, and starting a fluid bolus if they're hypotensive. These are critical, life-saving actions.
And this is exactly how you should be saying it. Don't just say, "I'm putting a cannula in." You make one clear, confident statement that covers everything. I am inserting 2 wide-bore cannulas, taking bloods, and starting a 500 milliliter saline bolus now. It's so efficient and shows you know exactly what you're doing.
Now for D, disability. You have to be quick here. Assess their consciousness using AVPU. Check their pupils. And please, whatever you do, do not forget to check a blood glucose level. It is such a common, reversible cause of confusion. If their GCS is low, you have to recognize the danger and say out loud, "I'm calling anesthetics for intubation." Okay, I know that was a lot to take in. But remember, you can pause right here and apply these exact steps by practicing this scenario on our platform. Repetition is absolutely key to making this whole protocol feel like second nature.
And finally, we get to E for exposure. This is a quick but thorough head-to-toe check.
You're looking for hidden clues, a rash, a tender abdomen, signs of a DVT. You check their temperature. But, and this is so important for showing you're a compassionate doctor, as soon as you're done looking, you state, I'm covering the patient back up to prevent heat loss and maintain their dignity.
Okay, let's switch gears for a second and talk about the news chart. This is not just a piece of paper. It's your tool for figuring out just how sick this patient is and guiding your decision to call for more help.
Here is the crucial point. No matter what the chart looks like, you never delay your ABCDE assessment to calculate a score. If the score's there, great, acknowledge it. If it's not, you do your assessment first, then you can fill it in. Your priority is always to treat the patient, not the number on the chart.
So once you've assessed and stabilized the patient, you need to communicate your findings clearly to a senior colleague. This is where the SBAR framework becomes your best friend.
This structure is just fantastic. It makes sure your handover is comprehensive, but also really concise. Situation, what's happening right now, background, what's the relevant history, assessment, what did your ABCDE show, and recommendation, what do you need from them? It's a clear, professional way to ask for help. And finally, let's talk about the mindset. You need to adopt what I call an emergency personality, because passing this station is just as much about your behavior and your communication style as it is about your clinical actions.
Mastering these habits is really what can separate a pass from a fail. You talk to the mannequin, not about it. You reassess constantly. You don't leave a problem unfixed, and you always prioritize their dignity. Doing all this shows the examiner you're not just a good clinician, you're a safe, empathetic, and systematic doctor.
So, let's bring it all back to this one crucial idea. Stabilization comes before diagnosis. You are there to keep the patient alive, not to solve the entire medical mystery in 10 minutes. Master the protocol, talk through your process, and put safety above everything else. If you can do that, you'll walk out of that station feeling confident, and you can practice this exact case now on Mediate.com.